For the remaining delegates, we plan to honor them this evening at gala dinner with the chief guest, please. So, as we don't have much time in between now, so we would only restrict the presentation of the shield or memento to few of our colleagues at this point. Now, my presentation would be in three main areas. I would like to focus these for a couple of minutes. First, the mental health in workplace, because this has been the theme by the World Federation of Mental Health as well as the World Health Organization also wants to focus on the same, and we have kept the same theme with a little change that we should be focusing on depressive disorder as well, keeping that in alignment with the WHO and the World Federation of Mental Health themes for the last year. Second part would be impact of depression on work functions, and then the goals of depression treatment as such. As you see that in year 2017, World Health Organization focused on the World Health Day on 7th April with depression and let's talk. That was the main theme. In comparison, World Mental Health Day by the World Federation of Mental Health in October 2017, the theme was again mental health in workplace. So that's where they wanted to focus and give prioritized significance to this aspect of the mental health aspect. We know that depression itself, as most of my other speakers, they have highlighted as well, and we can't ignore one particular disorder, and that is depressive disorder. And yesterday we were talking about whether out of depression cases will remain untreated. The suicide rate was 10 to 12% or 17% as Raza Rahman presented in one of his slides. But still, it's a very high rate, this maybe even 12% or 15% or 17% suicide rate, and that life loss is essentially far greater than life loss as road traffic accidents, which is utterly preventable. So that's how we are trying to focus again and again about depressive disorder and its management or treatment interventions as such. Depression is not that uncommon. About 350 million people globally, they are suffering from depressive disorders. Now, as far as the disease burden is concerned, comparing with 2004, when depression was ranked at number 3 in the disease burden and the lower respiratory tract infection was number 1, WHO estimates that by year 2030, depressive disorder would be the disease burden number 1. So that speaks about the significance of this particular disorder and why we need to focus on depressive disorder in particular. Beside depression, where it's leading to various other difficulties in our day-to-day work functioning, we reckon that there is a major economic impact globally. And for that matter, World Health Organization depicts that depression would be the leading cause of burden globally by year 2030, and the cost of depression in the European Union was estimated to be 92 billion in year 2010, and that was an indirect cost. In comparison, in China, the economic cost of depression was US $6.26 million in year 2002, and 84% of it was from indirect costs. So we can reckon that how much strong impact this disorder has. Lost productivity due to absenteeism and presenteeism, which was discussed in detail yesterday. But out of this, they both represent over 50% of all costs related to depression. We reckon that investment made in depression, that should match the disease burden itself. So treatment, non-responders, they are more likely to have low quality of life functioning, low likelihood of employment, greater likelihood of productivity loss, and as a result, greater healthcare costs, leading to eventually greater welfare costs as well. Depression Directly would have impact on working time that we know of. But in vitro depression, work abilities as well, 66% of employees. Sir, you just given the bell after 5 minutes. What have you done?
Very well.
For God's sake, if this is the first bell, then this should be the last bell as well. So, thoda sa patient. Okay. So the relationship between the cognitive symptoms and the functioning, that we need to focus as well. We reckon that in depression, 91% of the depressed employees, because of this depressive impact on their cognition, that's where they find the most and great difficulties. What should be the goal of depression treatment? We reckon, according to USA Medicaid guidelines, that by the year 2016, the major depressive disorders, they should be screened and evaluated on multi-dimensions. So, eventually we should be aiming towards a response, and then with the help of the medication, remission, and finally, the final goal should be the total functional recovery. Ultimate goal of the treatment, that should be to focus all three domains where depression is leading to problems like emotional area, cognitive deficits, and then the physical or somatic, because patients in endopark, they have more susceptibility, and most of them, they do present with the somatic component of depression as well. For that matter, we do reckon that our ultimate goal of treatment in depression should be to achieve full functional recovery, and for that matter, symptoms are essentially absent, and patient returns to pre-morbid functional status. Effective treatments available, you all know most of it, that serotonin's reuptake inhibitors, that is now the most widely prescribed group of antidepressants worldwide. Then comes serotonin norepinephrine, SNRI. Benzodiazepine should be given only judiciously and for the initial 4 to 6 weeks of intervention. Pregabalin is also being used, particularly targeting anxiety symptoms. Buspirone, again more for the GAD. Butrapiene, not published, but we reckon sometimes depressive patients, particularly with psychotic depression, they do respond to a combination. Low doses atypical antipsychotics would be help. CBT, of course, if the experts would be available, that would be help, and hypnotherapy and physical exercise, which we neglect most of the time. Out of the therapies, I reckon that the take-home message out of this should be that we should raise awareness about depression in the workplace and its effect on productivity. We need to promote early recognition of symptoms, and we need to reduce the stigma surrounding the mental illness in general and depressive disorders in particular. So I'll just take 2 minutes talking about the role of paroxetine controlled release in MDD, SAD, as well as PD and PMDD. We reckon that mostly we make ourselves familiarized with one or other compound which we feel more comfortable to prescribe in a clinical practice. Some people would be more comfortable with escitalopram, others would be more comfortable with paroxetine, others would be more comfortable with sertraline, but that is where we need to pick and choose in our clinical practice and set up what we reckon is helping a patient mostly. And we reckon that this is one compound which could be effective towards effectively treating and targeting both components. One, the depression, and the other one would be the anxiety symptoms for that matter. MDD, the major depressive disorder, the remission rate with this particular product, as you see in this study, that it did, in comparison to the placebo, it was outstanding with results, especially with the control release product. Sometimes we feel, as even in olanzapine, there are 2 products available. One would be the routine olanzapine, other one is peroxidase olanzapine in that preparation. So sometimes patients have better response with one modality in comparison to the other mode of the product itself. So that would be purely your own choice in your clinical practice. With this study, again we know that it is showing its efficacy with the controlled release trial that pooled analysis of 4 studies. So that does highlight that if you need to seek help for your patient population, I think in comparison to the paroxetine simple preparation, perhaps the control release would have better results for that matter. It could be equally effective in panic disorders. So in summary, it should have both antidepressant and anxiolytic impact. It should have efficacy in a broad spectrum of mood disorders, like a few of our other compounds which are pertaining to either SSRI group or SNRI group. So we need to make ourselves more familiarized in our clinical practice with one or the other compound, and that's where our patient population are going to seek help. So thank you all very much for your kind attention.
Thank you very much, sir. Request to chair for brief concluding remarks.
Can you hear me? बहुत तवील इंतज़ार हुई, इस इंतज़ार में तकमील कुफ्र हो न सकी, कभी तो मेरा खुदा भी मेरा खुदा होगा। सॉरी भट्टी साहब, थोड़ा सा मजबूरी आपको शेयर करना पड़ा, लेकिन मैं समझता हूँ एवरीथिंग वाज वंडरफुल। आई डोंट वांट टू कमेंट एंड माय टीम हैज गिवन मी the mandate that I should conclude, and I'll conclude it on just one verse of Urdu, and that is Mirza Ghalib ka कि वहदते हुस्न के जल्बों की ये कसरत, वहदते हुस्न के जल्बों की ये कसरत, ऐ इश्क दिल के हर पर्दे में आलम है परी खाने का। Thank you.
Thank you, sir. Chair is requested to please come forward for distribution of speakers' certificate. Professor Imran Ijaz Haidar, Professor Azizur Rahman Yusuf, Colonel Sahab,
आप ही हैं।
Dr. Sobia, Dr. Sobia Haki.
हाँ जी, Speakers was
Speakers.
First, I would like to invite Ms. Faiza Khalid. Dr. Ali Madi Hashmi.
आपको मैं
Noroz Ali.
सर हाइट एक जैसी
सर कोई तो है आपके मुकाबले का।
हम सब हो तो सामने आता।
Noroz Ali. Dr. Salman. Suhaib bin Bilal. Professor Jameel Hussain. Dr. Azim Khan. Dr. Nazar Shimran. Professor Muhammad Ishaq Sarhandi. Dr. Ghulam Mustafa Sombro. Professor Ahmad Bhatti.
आप तशरीफ रखें सर। अच्छा एक टाइम हो गया। डॉक्टर ख्वाजा हामिद माशाल्लाह हमारे बहुत ही एक्टिव हैं सर। सेक्रेटरी और बहुत ही तशरीफ लाए बाद से ख्वाजा साहब काइंड ऑफ यू फॉर बीइंग विद अस। थैंक यू सर। और अनवार खान सॉरी प्रोफेसर असद तमीजुद्दीन नहीं है सर आइए।
असद तमीजुद्दीन किधर है? अगर तमीज सीखनी हो तो असद तमीजुद्दीन जी
तो साथ बदतमीजी से कैसे चाहिए?
सर दोनों चीजें सिखा सकते हैं।
उसमें हम
प्रोफेसर अजीज उर्रहमान यूसुफ सही सर। सर आप कल हमें आप थे नहीं और जी सर वेलकम सर। आइए सर। प्रोफेसर अंजुम बशीर सर आइए।
यूके
प्रोफेसर इसाक संधी साहब बहुत बड़े सऊदी माशाल्लाह। और हमारे डॉक्टर इरफान रईस इरफान
डॉक्टर रईस
जी सर आइए। यार हम ऑनर करना चाह रहे हैं रात को गाला डिनर पर बड़े क्राउड। थैंक यू। ये शायद चंद दोस्त निकल जाए अभी। थैंक यू सर। कर्नल सज्जाद नकवी भी जाना था। We want to honor in the big gathering tonight at gala dinner through a chief guest, please, all the remaining delegates. So please show patience. We are not going to miss out any one of these. I think more or less this is all.
Okay.
Now please ready. Bhurban सामने ही है और वो थोड़ा सा सामने बैठे होते हैं। आपका Bhurban आपके पास होना चाहिए. Please walk in. और thank you very much and you should